Just to be clear, we want to make sure that we've got our personal protective equipment and we put that on before we actually enter the possibly hazardous environment.
Mr. Garrett, So when we first get on scene, we're supposed to do scene safe, then BSI?
No, new guy, it's BSI, then scene safe.
Oh, okay.
We want to make sure that we can properly protect ourselves.
Gotcha.
All right, guys, so remember, whenever we're doing an out-of-hospital transfer, if there's any blood products running, that's CCP only. We can't let advanced paramedics take that.
Yeah, Mr. Garrett, me again, yeah. Hey, so what would it be like if blood was advanced?
Well, blood bag, we've been riding out a long time together.
Yeah, paramedic school felt really long.
It's been fun, but with you past your national registry, it's time for you to go advanced.
I started me on Monday, by the way, but I'm really nervous about it.
Come on, blood bag, why are you nervous? We've been doing critical care together for years, and I've taught you everything I know.
So, guys, welcome to NEOP. Now, blood bag, you need to remember for your protocol exam, you have to pause compressions for rhythm analysis while using the AED for rapid shock.
Hey blood bag, congratulations on making it through NEOP. Your FTO is going to be just installed. I'll be checking in on you guys throughout training, and I'll look forward to seeing you for your MDI.
All right, well, first off, congratulations. You didn't need to be nervous at all. You did really, really great in your medical director interview. I was super impressed with the way you went back and you went through the dope mnemonic and you looked at your tube when I gave you 0 in title after you intubated. So that was great. So congratulations, blood bag, you passed. You're now advanced. All right, congratulations, blood bag. Here's your certificate.
Good morning, afternoon, or evening from wherever you happen to be watching this lecture from. My name is Austin. I am one of your critical care paramedics in the MAMSA system, and today we are going to be going over the new blood product protocol. This will give all paramedics and all advanced providers in the MAMSA system the ability to carry blood on transfers between 2 different facilities. So first thing to cover, blood is more than just the sticky red stuff that comes out of your trauma patients. I know that is a big shock to all of us. So with that, welcome to Blood Products 101. Currently, if you are looking at your protocol app, it will be under the critical care procedures. However, when this protocol goes live, you will see it under the standard advanced protocols. So these are the couple of types of common blood products that you will see. Firstly, whole blood. The next one that you will see is packed red blood cells, or PRBCs. You will see a subcategory of the PRBCs called wash pack cells. The next one is going to be platelets. Then we have your fresh frozen plasma, or FFPs. After that, we have your cryoprecipitate, commonly known as cryo. This determines the compatibility between the patient and the blood that they will be receiving. The ABO refers to the actual antigens of the blood group, and then the RH, or rhesus factor, indicates whether the blood is positive for the rhesus protein. So AB positive is going to be the AB antigens along with positive for the rhesus factor. General rule of thumb, O negative is your universal donor, so anybody can receive O negative blood, and AB positive is the universal recipient. Generally, during the situations where we will be utilizing blood in emergency transports, it is going to be your O negative. Your EKG, your thermometer. Then we have your blood tubing. This is an important factor that we must monitor every 15, 45 minutes, and 1 hour after the transfusion has been initiated. Oral temperature is going to be the preferred route of gathering your temperature. However, if you do have to utilize another area to gather your temperature, whether that is axillary or rectal or temporal, we just need to make sure that we are being consistent from measurement to measurement. One of the big things that we need to note is if the patient spikes a temperature of greater than 2 degrees, I know that doesn't seem like much, but greater than 2 degrees from their baseline before the transfusion starts, we must stop the blood. Less than 2 degrees, we're going to be cautious, we're going to monitor it. However, greater than 2 degrees or at 2 degrees greater than baseline, it needs to be stopped all time, every time. This is a specialized Y tubing where you will actually attach the blood on one spike and the fluids on another. Typically, this is going to be only utilized with normal saline from the sending facility. And we will not carry this tubing on the ambulance at this point in time. You will have to get this from the sending facility. The Y tubing has a special filter specifically made to filter the blood coming through this. That way we can ensure that no clots are making it into the patient after this blood has been thawed. You will prime this tubing with normal saline or whatever fluid the sending facility has ordered. Rarely they might use something like Normasol. However, LR is contraindicated to be utilized with your blood products. You will prime this tubing with normal saline, and then you will close off the saline. You will then start the blood at the infusion rate prescribed by the sending facility. Most of the time this is going to be a gravity infusion in your emergency transports. However, in cases where they are treating a specific condition, usually some form of anemia or cancer, or in special GI bleed circumstances, there may be a set infusion rate prescribed by the sending doctor. How you will accomplish this is going to be that you will attach the Y tubing to your extension pump set, so not the pump set that actually has the spike, but the pump set that will attach from tubing to tubing. And then if the blood happens to finish during your transport, make sure that you close off the blood, and then you will continue running the prescribed fluids at that same rate until you have flushed all of the blood from the line. You will need to set the infusion for the total amount combined between the bag of fluids and the bag of blood that you will be infusing. And then once the blood finishes, you will just transfer between the blood bag to the saline bag by closing off the blood. The most common being your allergic reactions and your febrile non-hemolytic transfusion reactions, or FNHTR. So allergic reactions, you're going to be utilizing the same protocol that you would always use to treat any other form of allergic reaction, whether that is mild, moderate, or severe. Make sure that you are following your standard protocol. The febrile non-hemolytic transfusion reactions is going to happen in less than 3 hours from starting your blood transfusion. If you have a rise in temperature of less than 2 degrees, but greater than 1 degree, you are going to be giving this patient Tylenol. Unless this patient is intubated, this patient should be getting oral Tylenol, standard 1 gram. If you have a rise in temperature greater than 2 degrees, you will be stopping the blood. The febrile non-hemolytic transfusion reaction will be accompanied by symptoms such as chills, muscle rigidity, increased respiratory rate, a change in blood pressure, whether that is high or low, secondary to the infusion, and commonly it will have some anxiety associated with it, along with a pretty severe headache. A couple of the uncommon transfusion reactions that you might see are going to be an acute hemolytic reaction. So your classic symptoms of the acute hemolytic reaction are going to be your fever, your flank pain, and your red or brown urine. This is commonly only going to be seen if we have a Foley catheter in this patient. Other symptoms are similar to some of your other reactions, including chills, hypotension, renal failure. Again, so if we have a Foley catheter in place, we need to make sure that prior to transport, we are going to be marking the amount of urine in the Foley catheter bag, so that way we can monitor for signs of impending renal failure, decreased urinary output. Some other symptoms that you need to watch out for are going to be the back pain and signs of DIC. Another reaction that you might see is commonly known as a trolley reaction or a transfusion-related acute lung injury. This is going to be similar symptoms to your acute CHF exacerbation. So you're going to have the fever, chills, dyspnea, tachypnea, tachycardia, hypotension, hypoxemia, and non-cardiogenic bilateral pulmonary edema, leading to progressive respiratory failure, generally seen within 6 hours of starting the transfusion. So you will treat these patients exactly the same as your CHF patients, aside from the aspirin and nitro. So make sure that you are watching their blood pressures, make sure that we are putting these patients on CPAP as necessary. Then we have our taco reaction. Transfusion-associated circulatory overload. These are the patients that you're going to see pulmonary edema, severe hypertension, excessive fluid volume. So these patients are going to be experiencing extreme acute respiratory distress, very similar symptoms to your trolley reaction as far as the CHF type symptoms. So make sure that we are watching those very closely, and we are making sure to treat your respiratory distress associated with these reactions. Again, follow your protocol. If you see something, treat it. You will need to be getting all of the blood paperwork. A couple other slight differences is that you will need to make sure that every patient that has a blood transfusion going, you should be monitoring their labs. So make sure that you are documenting all of the sending facility's most recent set of lab work, whether that is your basic metabolic panel and your CBC or whatever else the sending facility has done most recently. The most important one is going to be that CBC. All of these papers, you need to make sure that you are documenting both in the chart itself and attaching pictures of all pertinent paperwork, including your labs, your transfusion slips, and your face sheets to go with the patient. These should have pictures attached in the chart. Now we'll start a little bit of charting. I know it's the boring part, but we have to do it. Without the charts, we will not be getting paid. Without the charts, we cannot maintain proper care of our patients. So you need to make sure that you are documenting the patient's blood type under the blood product tab. This will be available to you in the charting field once you select that you are doing an interfacility transfer. It will pop up under your patient care tab. It may not be there under all transports, but it will show under your interfacility transfers once you have selected an interfacility transfer as your primary impression. Now, the blood product charting is pretty straightforward. Just make sure that you are watching your screen, filling in all pertinent parts of the documentation. You need to make sure that we are documenting what time the facility itself started the transfusion if it was started before your arrival. All of the information on the blood product slip, aka the same thing that you're going to see on the actual blood bag itself, all of that information needs to be documented in the chart. You will see slots for what type of blood product you are receiving. You will have boxes to notate the most common types of blood products, similar to what we went over earlier in the presentation. If there is something else going that is a blood product, something like albumin, that will be documented under the blood product other slide. And then you need to document how you are giving the blood, whether that is by gravity or a set infusion rate. We need to make sure that we are documenting how much blood has been given. There will be slight variations in the amount of blood that will be given. This will not be a standard 250 cc bag. It will not be a 500 cc bag. There will be a specific amount documented on the blood bag that will tell you exactly how many mLs are in that bag itself, and we need to make sure that we are documenting very specifically the amount of blood in that bag. And then we need to document where the blood is running. If they have multiple IV lines, we need to make sure that we are distinguishing between what IV line this blood is running through. It can run through your PIC lines, your central lines, and all standard IV lines. However, along with the same principle that we follow for other transfusions, we need to try and make sure that this is a large bore IV if we are running it through an IV. 20 is your absolute minimum, but we prefer 18s or above. The blood products should be running through the most distal port of a PIC or central line possible. Now, when we start getting into the triple and quadruple lumen, this is where it really starts to matter as far as what port. The most distal port is going to be your largest bore of the 3 or 4 lumens in your central catheter, and that's why we want to utilize that for our blood products, being that the smaller the lumen, the more pressure that is going to be placed upon these medications, and the more pressure that we are placing on these blood products, the more likely we are to get secondary clots with this blood product administration. All other fluids or medications should be running through the ports that are closest to the patient's central cavity, with the most central line being reserved for your vasopressors. And then lastly, we need to make sure that we are documenting if the patient had any kind of transfusion reaction and what we did to treat it. And of course, with any infusion, we need to make sure that we are documenting what time specifically the transfusion was completed. Now, earlier we talked about having the blood finish and then running the rest of the line through with whatever fluid was prescribed by the sending doctor. This time completed is not going to be the end of the saline bag running with the blood. This is going to be what time did you stop seeing blood go into that IV port. And then, of course, we need to make sure that we are signing. This is going to be different than the signature that you will see at the very end of your chart that goes associated with every chart that we write. This is something that is going to be under the blood product tab specifically. So both you and your Rockstar EMT or paramedic partner that you are running this call with will both need to sign as witnesses, saying that we verified all blood product information and verified that this was an appropriate medication administration because blood is considered to be a medication. The easiest way that you can make your life as simple as possible is to go over and use your power tool section. We have these tabs for a reason. Take a look. If you like it, use it. I think it makes your life a world easier. So you will see under your Power Tools tab, you will see both a blood product administration tab and a labs tab. The labs tab is going to have your basic metabolic panel and your CBC in that tab. That's the easiest way to make sure that you get all pertinent labs to this patient's care. And that's about all we have, my friends. Again, my name is Austin. I am one of your critical care paramedics, and I am also an FTO in your system. If you have any questions, don't be afraid to reach out to anyone in your OMD team, anyone in your critical care team, or one of your FTOs. It's been a pleasure teaching you guys today, and I hope to see you guys out there.